Alors, mesdames et messieurs, je vous souhaite le bienvenue. Ladies and gentlemen, welcome to the 10th installment of the Andrew F. Holmes Dean of Medicine Distinction Lectures. We are proud to host this lecture in Dr. Holmes' name, one of the 4 co-founders of McGill's Faculty of Medicine and McGill's first Dean of Medicine, to provide a forum for stimulating academic exchange. Made possible through the generosity of the Rose Weiselberg Foundation, these lectures salute those who are outstanding in the health sciences, while celebrating the scholarship that is the backbone of all we do in education, research, and healthcare at McGill. They also open the doors to our undergraduate, graduate, and postdoctoral students to give them an opportunity to learn and exchange with today's international luminaries. We are thrilled to be hosting today's guest lecturer, renowned surgeon, writer, and public health advocate, Dr. Atul Gawande. A 2-time graduate of Harvard, a Rhodes Scholar, Dr. Gawande is a practicing general and endocrine surgeon at Brigham and Women's Hospital in Boston, as well as professor in the Department of Health Policy and Management at the Harvard T.H. Chan School of Public Health, and the Samuel O. Tier Professor of Surgery at Harvard Medical School. He's devoted to reducing suffering and saving lives through systems innovation and making surgery safer globally. In 2006, he was named a MacArthur Fellow for his work investigating and articulating modern surgical practices and medical ethics. As many of you in the audience know, he is a prolific writer, having written extensively for Slate and The New Yorker. He has received 2 national magazine awards, as well as the Lewis Thomas Award for Scientific Writing, and has authored 4 best-selling books, including his most recent, Being Mortal, Medicine, and What Matters in the End. Dr. Gawande has challenged the medical community to acknowledge its own deficiencies and is a firm believer that society must step back and look to new ways to practice medicine with a renewed focus on improving the standard of care for patients. Tomorrow, I will have the privilege of participating in convocation where Dr. Gawande will be presented with an honorary doctorate from McGill, an honor for which he is most deserving. Please help me in welcoming Dr. Atul Gawande.
Thank you for that welcome, and thank you all. I have to start with a disclaimer. I am not an expert particularly at any of the things that we talked about. I started writing as a resident, and coming into this as a trainee, my perspective on both the research that I do about how our systems in healthcare work and the writing that I do has been to think of it through the eyes of where I was as a trainee, where what I was puzzling about was, how do I get good at this thing we are trying to do? And then why is it so hard? Well, as time went on and I kept asking those questions and writing about trying to struggle through everything from how do I get good at surgery and be allowed to make mistakes on people, all the way through to entering practice and wondering about how I could make the imperfections of the systems around me more successful, I began to reflect on the fact that there was a whole group of patients that I hadn't given very much thought about. I opened my most recent book, Being Mortal, by saying that I learned about a lot of things in medical school, but mortality was not one of them. We were there as students, and I think mostly as our professors, to understand how the body works, how the mind and body then can fail, how illness and injury happen, and then how to fix them. But what we had not spent much time thinking about was what it meant to deal with the unfixables. What happens when you could not fix those problems? And what I had not appreciated was how much of my practice, when I would go into, actually come out of my training and open my doors to surgical patients, how much of what I was doing was talking to people who had often unfixable problems. The hardest part of the question of dealing with unfixables for me was, what does it mean to be good at taking care of people with the consequences of advancing illnesses, whether it be organ failure, a cancer, or simply the processes of aging. What does it mean to be competent? As one example, I got a call from a neighbor, the husband of Peg Batchelder, who also happened to be my daughter's piano teacher. And I wonder if my slides are up. Yeah. And this is Peg. And her husband was calling to ask me advice. He said, Peg is in the hospital. All of you who are here in the clinical world get these questions all the time. I knew a fair amount about her journey. She had had a cancer diagnosis a few years back, a rhabdomyosarcoma. That is to say, a cancer in the soft tissue, the muscle of her pelvis. It had enlarged to significant size, involving the bone. She ended up having to have 1/3 of her pelvis removed, a hemipelvectomy, then have reconstruction of her pelvis with metal, then radiation and chemotherapy. When her wound broke down and became infected, they had to remove all of that hardware and then spend months waiting for it to heal and then reconstruct again. It was, she said, her year in hell. But when it was done, the disease was gone, and she was able to return to what she loved most, which is her teaching. She was an extraordinarily talented piano teacher, had trained a roster of people who'd gone on to careers in music. She was 62 years old now. She got around with a cane, the Canadian crutches, with the that wrap around your wrists so that you could get around. And with only that hobbling her, she was able to return to a very full life with an excellent prognosis. And then she was diagnosed with myelodysplastic syndrome, a leukemia-like condition that is caused by chemotherapy. She was found to have dropping blood cell counts, and then had to go on to chemotherapy for that. She insisted on continuing to teach through her course, and every once in a while we would, have to move my daughter Hunter's piano lesson around in order to accommodate her chemotherapy schedule. But Peg continued all the way through this. And then there were 2 weeks in a row where the lessons were canceled, and that was when I got the phone call from her husband, Martin. I asked him to put Peg on speaker with him, and she told me that the treatment for her myelodysplastic syndrome was not working. Her blood cell counts had continued to drop. She developed fevers. As part of the workup for what they suspected to be infection, she had scans throughout her body, and then they found that her original cancer, the rhabdomyosarcoma, was back, now in another part of her pelvis and throughout her liver. As it advanced, it slowly caused increasing amounts of pain, and then in the previous week, couple of weeks, she had become hobbled to the point that she had difficulty getting out of bed and then became incontinent in bed. And that was for her the final straw. She was ultimately admitted to the hospital where she remained, despite treatment, in pain, incontinent, and she wanted to know, what should they do? I said, well, what did your doctor say you should do? And she said, not much. They were giving her almost daily transfusions to keep up her blood cell counts. She was on steroids to suppress the tumor fevers. She was on hefty doses of pain medicine, but still struggling. Most of the clinicians had said that there was no no real chemotherapeutic option and said that she could go on comfort measures. There was one holding out a hope of an experimental therapy, having an experimental transplant and stem cell transplant. And so the puzzle was, what should she do, she wanted to know. And this is in many ways the moment that we debate. We debate it at our national levels, in the public domain, and privately. And the puzzle is, what do we want for her at this moment? Her condition is incurable by any known means. So should she try an experimental option? Should she try for something? She has so much to live for. Should she go for it, no matter what? Or should she, as she saw it, give up? Comfort measures was just that to her. And I think the core of the puzzle for me was, what's the goal here? And certainly, what would it mean for me or any of us to be really good in this situation? I'd hit this moment over and over in my career primarily as a cancer surgeon. I'm an endocrine surgeon and general surgeon, and running into situations in many different forms where you didn't know that you had any solution to offer, but you weren't totally ready to say there was nothing, right? And so I went in search of trying to find an answer to how to think about this situation, how to understand what being excellent would really mean. And I found along the way that a good answer was tied to a seemingly unrelated study. It was out of a set of work that a Stanford professor of psychology named Laura Carstensen had done. She'd run a landmark series of studies tracking and studying the emotional lives of a group of people as they aged. It was several hundred patients in a cohort, ages 18 to 94 when she started in the late 1980s. And she began tracking them over the course of the rest of their lives. That study has continued onward for now almost 30 years. And she's found several extraordinary and interesting things. Number one was that as people age, their desires change. And I want you to hang with me as I walk my way through these, and you'll begin to see why I thought this mattered so much. So our desires change in the sense that there was a kind of young signature and an old signature. The young signature is that people are focused on getting, having, and achieving, on acquisition in their lives. And then as we get older, we get focused on a much smaller number of people. We're not trying to get and have as large social networks. We become focused on a smaller, more intimate group of people. And then we are focused on deeper relationships with them. We become less focused on acquiring materially. There also becomes changes in our emotions. For example, people become capable of an emotion that most young people don't even know how to understand, an emotion they called poignancy, that bittersweet feeling of being able to have a positive and a negative emotion at the same time. The other thing that really stuck out to me was that, not surprisingly, as you follow this group of people over time, their overall health declines, their physical abilities, and in some cases mental abilities, decline, but they become happier. The likelihood of having anxiety, moderate to severe anxiety, declines with age. The likelihood of having moderate to severe depression declines. Sense of calmness about life, satisfaction. You're more likely to have love in your life after age 60 than before. And And so the first thing I started wondering about is, this is all what we would describe as wisdom, right? Being able to not be focused on the material goods of life, become more focused on the relationships you have in life and strengthening and building the ones that really count, on being able to find ways to have a calm perspective on your life. And so, of course, the first question that I thought of was, why does it take so long? Why do you have to get old to discover these things, right? And so there have been lots of theories about that. MRI studies suggesting there might be structural changes in the brain, a kind of learning theory that you need to have the experience of time, practice, and exposure to the many ways in which life operates before you come to those places. And what was interesting to me was that Laura Carstenson's studies showed that that was wrong. She started these studies, remember, she's at Stanford in the late 1980s, early 1990s, and that's the peak of the HIV/AIDS epidemic, when we did not have treatments. And so she had a cohort of young men who were diagnosed during the time they were in the study with HIV/AIDS, and then subject to the complication, one after another, of a decline, because it was not until after 1995 that we began to have really effective treatments. And what she saw was that the group who became ill went from the young signature to the old signature. They went from a focus on acquisition to a focus on relationships. They became less worried about trying to have a maximal number of friends and much more about the people that they were closest to. They became calmer. They became less likely to have anxiety and depression. And then an interesting thing happened. This study continued into 2001, and 9/11 happened. She saw an entire cohort shift from the young signature, the entire population from the young signature to the old signature. And it was the recognition that dawned on her, on Laura Carstensen, that when we become aware that our lives are fragile, we change. When we become uncertain about our future, about our mortality, we become less likely to want to go to that nightclub at 2 a.m. and want to go see your family. And then about 3 months later, after 9/11 had passed, we wanted to go back to that nightclub again. There are a few things that came out of this for me. One is that well-being is possible even under severe constraints. We're talking about people who were terminally ill or facing a threat to the country. And that runs against some of the ways we think about what happens when people are vulnerable or facing illness. It's also clear we've undergone a dramatic change over the last century. Before 100 years ago, for most of the time human beings have been alive, there was no clear relationship between your aging and your risk of dying. You could be a child who gets a strep throat, a teenager who has a compound fracture that was often fatal, a young woman undergoing a simple childbirth. On up along the way, there was a threat at any moment in your life of something that could claim you. And so fragility was ever present, and therefore you see in literature and along the way that there is awareness that there are priorities beyond health, things that people begin to think about. In the death of Ivan Illich, we forget that Ivan Illich sounds like an old man, but in fact he was in his early 40s as a magistrate. Well, one of the pieces of literature I zeroed in on was a book by a philosopher who'd been writing during that period, and then he compiled some of his work in a book in 1908 called The Philosophy of Loyalty. It's by Josiah Royce. And what he was wanting to know was, why did people, it's not a question we think about these days, but the question he was asking is, why do people so often find that just being safe and well-fed and healthy and comfortable seemed insufficient in their lives. And he believed that there was an intrinsic human need to live for something larger than ourselves, to live for something beyond ourselves, to have things that you would actually sacrifice your health or well-being for. And whatever that is for you, he called your loyalty. Your loyalty may be to your family. It may be to your country. It may be for an ideal like justice. It may be for beauty. It may be for God. But he was contrasting it with an individualist view that your self-interest is what truly comes first. Kind of, rational economist view. That scratch under the surface and you can find exactly how much you need to pay before someone would, sacrifice anything beyond themselves. But he goes through a series of experiments, kind of thought experiments in the book that I found completely fascinating, that pushes on the idea that we actually are all that self-interested. For example, one of the experiments, he says, it's a puzzle, which is, why do we care about what happens to the world after we die? If we ask, if you were told that half an hour after your death, the world would blow up with everybody in it that you know, would you care? Most people would. There's always someone who says they wouldn't. Most people say they would, because then they feel that their life wouldn't have had meaning. The meaning comes from something larger than who you are. If our own desires were the only things that matter, if our own achievements were the only thing that mattered, then you wouldn't care what happened after the world, if the world were to go away. Well, today we get to live our lives, mostly as if we're immortal. We get to spend virtually 90+% of our lives not having to live the way that people did for most of history, constantly aware that it could be taken from you at any time. It's increasingly rare to have circumstances that would claim your life before the age of 65, now increasingly 75. And so the result is we have a very particular view of what a good life is. If you ask me as a clinician what my job is, it's to help people have a good life. And by that I mean to help them be healthy and independent. That is to us what a good life is. And that's what I have always thought of as my job. And the problem with that is it doesn't fit with a world where people are aging, becoming frail, a world of sickness and chronic sickness as an increasing part of people's lives. Our medical focus is on safety, survival, independence. And the result is that we are lost when these things are no longer possible. We lose sight of the idea that well-being might be bigger than a person's individual health or safety or survival. And when that happens, the result is suffering. Along the way, I interviewed ultimately more than 200 people about their experiences in themselves or in their families with serious life-limiting conditions, whether it's a terminal illness, chronic debilities, aging with severe disability. And along the way, I ended up interviewing people in their first month of arriving in old age homes, in nursing homes where they needed significant nursing care. And they were miserable. They described to me a world in which you had your furniture, you couldn't bring your own furniture because it wasn't safe. A place where you had set scheduled times when you could wake up and go to sleep. You'd wake up for the pill line, for breakfast that was on a set schedule. You didn't have any choice about having a roommate. You give your roommate whenever you wanted. You couldn't have a drink at the end of the day. What does this sound like to you? Exactly. It's prison. The most common complaint I wrote about my wife's grandmother, and every time we saw her, for years she was in the same place, she would say, "When are you taking me home?" It's the most heartbreaking thing you could hear, because home is a place where you have control over these things. We have a say in the risks that you can take. I met a 85-year-old woman who had severe Alzheimer's disease, and she had reached the point that she had been ordered a medically ordered pureed food only diet, and she would be caught stealing cookies from her neighbors. And they would confiscate them and write her up. Call up the kids. She's stealing cookies again. You just wanted to say, let her have the damn cookies. Here she is expressing the one joy she has in her life. Every day is expressing this joy. Well, it's not just in a nursing home that you see it. You see it in our own hospitals. And you could see it, you could see the suffering with Peg Batchelder. Lying in that bed, 2 weeks, in pain, transfusions every day, steroids, this question of an experimental treatment or not. Neither she nor the treatment team had any imagination that a life worth living might still be possible. We have an ongoing assisted death debate. And that debate is about what it means to have a good death. But to me, the goal is not a good death. The goal is as good and full a life as possible, all the way to the very end. And that's what we seem to have lost sight of. Well, as I was doing this research and meeting all kinds of people, I was talking to lots of experts, people who saw a lot of people go through this phase of their lives. Geriatricians, palliative care clinicians, geriatric social workers, nursing home directors, a guy who called himself a nursing home abolitionist. And I learned about a whole body of literature that I found incredibly fascinating, and probably the emblematic study was one that was done at the Mass General Hospital by a team led by Jennifer Temmel, a palliative care clinician. And it was a study of patients with stage 4 lung cancer. So this is widely disseminated lung cancer, and for all of the patients in this cohort, it was uniformly fatal. Median survival was 11 months. And they randomized those patients, half of them to receive usual oncology care, and the other half to receive usual oncology care plus seeing a palliative care clinician from the very beginning of their diagnosis. Now, I'm a cancer surgeon. That's not the way I usually called in the palliative care folks. You know, when I'd have a patient say, maybe we should see palliative care, I'd usually say, no, it's not time for that yet. We still have options. It seemed to me that they were like, what, you know, the way I'd heard about it and thought about it was, this is the group of people you go to when there aren't options left. But that's not the way that they turn out to see their job. And the study exemplified it, because the group who got the early palliative care, a group of people focused on your quality of life, while the oncologists were focusing on the quantity of life, the group who had the palliative care clinicians in their care ended up doing better in multiple ways. First of all, one way was that they had less toxic therapy along the way. They had about a third less chemotherapy total. They were about half as likely within 60 days of death to have received chemotherapy. They were about more than 80% lower likelihood of having chemotherapy during the last 2 weeks of life. They spent less time in the hospital. They spent less time in the intensive care unit. They were less likely to die in either of those settings. They started hospice care far earlier. They had lower rates of suffering measured by anxiety rates, depression, and other symptom scores. And the kicker was, they lived 25% longer. The early palliative care group outpaced the standard care group. If this was a drug, this would be a multi-billion-dollar seller. But it's just palliative care. And what it meant was that somewhere along the way, we were unable to tune the care of patients to meet either their quality of life or quantity of life goals. And that there was something the palliative care clinicians were doing that was different. Well, this was pretty fascinating to me. I thought, there's something we could learn about that might be helpful. What was interesting, and I ended up interviewing the clinicians, it's like half a dozen who were in this trial. Like, so what are you doing that's worth that? And a third less costs. And then I interviewed a whole bunch of others. And each time I gradually came and I realized that what I was asking them was, what should I do differently the next time I have one of these patients? Because the solution from this might be, everybody should have a palliative care clinician who's got any kind of serious illness. And the problem is that at the current rate, there aren't enough of them to go around. Even if you put the palliative care clinicians and the geriatricians together, you might get to like 5% of the people who die from cancer. And that's only a quarter of the people who will go on to die in the world. It also just bothered me, the idea that like, they do quality, we do quantity. Like, why are we outsourcing that? So I would go and talk to them and I'd say, so next Tuesday, when I'm in my clinic seeing someone, what should I be doing differently? We have bad news conversation. Things didn't turn out the way we hoped. We now have to make some new choices about where to go. What should I be doing differently? And the number one thing I heard was, you should stop talking so much. And I realized it pressed on a very basic idea of what it means to be a clinician for me. In my training, we had learned all about the bad old days of paternalism, right? Where the doctor, faced in a bad news situation, may or may not even tell you what's going on. They may not tell you this is cancer, the cancer's back. They'll just tell you what we're going to do. No options, no anything. And we rejected that in the 70s and in the 80s to give people information and choices. And in my training, that's what I came to think of myself as doctor informative, to help people understand what are the facts of your situation, what are your options, what are their risks and benefits, pros and cons, and then I would say, now what do you want? So the result is, if you were mapping my conversation in my clinics, I found like when I went into that clinic the next Tuesday, I was talking 95% of the time. One of the palliative care clinicians said I was an explainaholic. Because I'd say, now what do you want? And then the patient would say, what would the patient say? What would you do, doctor? And then I was taught to say, no, 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 no. That is not for me to decide. That is for you to decide. Only you know you. I'm me, you're you. You tell me what you want, right? That's the whole thing we're supposed to do. And it was always incredibly unsatisfying. And it felt to patients like we were abandoning them in these key moments. It's the kind of conversation that Peg Batchelder was having with her doctors, right? Very friendly, lovely, warm, caring people. And they would say, well, do you want comfort care or do you want the experimental option? And they'd say, what do you want? And then she'd say, well, what would you do? And then they'd say, oh, no, no, no. So then she'd call me up. So I'm on the phone, like, what do I do? And I didn't have an answer for that. And what the palliative care clinicians were saying is there's a third way of thinking, and it's the way that they think. And it's the way the geriatricians think and others. And that is that your role is to be a counselor. And that means a very particular thing. That is, a counselor works to hear from you what your goals are. what your priorities are, and then to match those options that are discussed with you, but to say this one is the one that seems to match those goals best. Recently, in Massachusetts, we ended up in my research center. So alongside my writing, probably people hear less about my research side, which is to do experiments and studies in how we make some of these good things happen and at system level. And as part of that work, we've been doing some surveys now, starting a year ago and continuing in the state of Massachusetts, tracking a set of questions in the population. And one is whether people want their clinician to be discussing end-of-life issues with them. You know, what might happen, what our priorities for care really are. And the answer is overwhelmingly yes. 85% believe it's sort of like a duh kind of thing. In the United States, where this was equated with death panels, it was actually a significant thing that it turned out everybody didn't think it was a death panel, just having these conversations. But the striking thing was that even for people who'd had a serious health condition that was requiring ongoing treatment and had resulted in hospitalization during the year, only a quarter had had those conversations with patients. More to the point, when they did, people had to initiate it themselves. 2/3 of the time, we were unwilling to have that conversation. They had to push us to be able to have that. And then the striking thing was how much difference having these conversations made. First of all, about 30% of the population had observed a loved one go through a dying experience in the previous year. I didn't have any understanding how real this was and common in people's lives. Second, when you ask them what the quality of care is, they describe numbers that are really dismal. So the extent to which the healthcare, when you've had a discussion with the healthcare team about their wishes, the wishes of a family member for the end of life, when they have not had that discussion, they have a 70% likelihood that their wishes were not honored along the way, which is pretty galling. But when they've had that conversation, it's an 83% likelihood that their wishes were honored along the way. Furthermore, when there has not been this conversation with a team, it's about 80% have only good, fair, or poor care. If any of you have ever seen patient satisfaction scores, like 90% being excellent or very good is a mediocre score after surgery or after a hospital admission. These are appalling levels of quality people describing for their family members when there's been no conversation. But having a discussion about their priorities, their goals for end of life, leads to 84% reporting an excellent or very good care in one of the most distressing experiences in people's lives. Well, the puzzle then for me was, all right, so how do you have this conversation? Whenever I would just go up to people and say, so what do you want? What are your priorities? What are your goals? They don't have much of an answer for me. And it's an art, it turns out, to elicit from people what their priorities and goals are. And it's one that we haven't really been taught or developed. So I just went around asking the palliative care clinicians, what should be my checklist for this conversation? And Susan Block, a national figure in palliative care, literally gave me the checklist. And it's this. She just dictated it to me. I wrote it down, and then we turned it into this. And what it is, we've since done some testing and working with the wording for understandability, but the basics of it is that a counseling conversation starts with, what's your understanding of where you, the patient, are at this time with your health or with your illness? What information about what is likely to be ahead with my illness do I want from my clinician? And then a series of questions that helps you understand their goals and priorities. If your health situation worsens, what are your most important goals? What are your biggest fears about the future with your health? What is the minimum quality of life you would find acceptable? What are you willing to go through and not willing to go through for the sake of more time? And have you talked to your family members or your proxy to let them know your answers to these questions? Susan Block, who's become a good friend, told me about having this conversation with her father, who had a lesion in his spinal cord that threatened to make him quadriplegic. And having this conversation, he said the minimum quality of life he'd find acceptable is that if he could eat chocolate ice cream and watch football on television, that'd be good enough for him. It's the best living will ever. You know, most living wills are like, do you want chest compressions or would you want to be on a ventilator? Like, no one has as their goal that they want to be on a ventilator or have chest compressions. The question is, if I get those things, can I eat chocolate ice cream and watch football on television? Or whatever your answer would turn out to be. We ended up running this as a trial, which we've been running at the Dana-Farber Cancer Institute, which has been to teach clinicians how to have this conversation using this kind of fairly simplistic structure. And the study has been a multi-component intervention of identifying patients at highest risk of dying. Again, this one's also not terribly sophisticated. We ask people about their panel of patients that they are seeing. Would you be surprised if any of them died in the next year? The ones you would not be surprised if they would die, among a group of oncologists, the likelihood that they died in the next year was 40%. So it's pretty high risk of mortality, less than 5% in the group that they would be surprised. And that meant there's a group for sure you need to be having this conversation with, because their life was potentially in change. We trained the clinicians in a 2.5-hour training to practice using the Serious Illness Guide. A copy was sent to the family to let them know the kind of conversation they might be having. We had email reminders for the clinicians when the patients came in for a clinic visit, and we had a documentation module in the electronic medical record. The results, this is preliminary data, which we have, however, presented at ASCO. The likelihood that, first of all, in the control group, we randomized the entire Dana-Farber Cancer Institute, by the way. We got 80% of the clinicians to participate in being randomized, and half of them got the training and half didn't. So in the control group, first of all, the existence of the trial bumped up the likelihood they even had these conversations, because there had been a previous study that had shown that we were having this conversation less than a third of the time, and it went up to 70% having a conversation. But in the intervention group, it was 90%. The timing, it was earlier, so it was at closer to 5 months before death instead of just a few weeks. And it was a better conversation. It was not just a DNR discussion. It was about goals beyond code status for 95%. And then the results so far, again preliminary, is we're replicating the results of the TEML study with non-palliative care clinicians. That you can see that there is a reduction by half in the rate of anxiety and in the rate of depression that these patients have. We see no difference in survival. And so here then, for me, was a way that I could begin to think and talk differently. And so with Peg on the phone and her husband Martin, having learned how to try to think this way, and by no means with any kind of proper palliative care training, I began asking them the questions. I said to Peg, so Peg, what's your understanding of where you are with your illness at this time? And she said, flat out, I'm going to die. There's nothing more they can do. And she was kind of pissed. She was angry about it. Martin later told me that was the first time he'd heard her say that, flat out. Said, what are your goals if your health worsens? And she said, I don't have any that I think are possible. The palliative care folks hadn't told me how to handle that one. So I just went to the next question. So I said, what are your fears for the future? And she ran off with a litany. Facing more pain, suffering more humiliation of losing her, even more of her bodily control, dying in the hospital. She said, I've been here for days, just getting worse. I'd been on visits as well with a hospice team as they made their rounds. And I was really struck in going around with them. I remember there was one patient who had congestive heart failure, came to the door, huffing and puffing when we came on her visit. She seemed really short of breath, like this could happen at any minute. And suddenly the hospice nurse went to work. She was listening to her lungs. She went and checked the nebulizer. She checked the oxygen. She checked her meds, and she realized her meds had been out. They hadn't been refilled. The nebulizer was broken. The oxygen was working. She got on an emergency call to get the nebulizer fixed. She called the daughter to make sure it turned out that the prescriptions were at the pharmacy but hadn't been picked up. Stood by her till all those things got arranged. And then we went on our way. And I said, what were you doing back there? I thought when I think of hospice, what I used to think hospice nurses were black hooded nurses who came around with an IV morphine drip to send you to the great beyond. And so what's she doing? I thought you're supposed to at least let nature take its course. She said, no, that's not my job. Medicine thinks of its job as sacrificing your time now for the sake of time later. But she said, what I think of my job as is using our medical capabilities to give you your best, most full possible day today, whatever that means for the future. And the studies indicate that for people in serious and life-limiting illness, that doesn't shorten their lives. It often extends them. But most importantly, it makes a life worth living possible. And so I said to Peg that I'd met these folks from hospice, and what I'd learned from them is that the choice is not about whether you want to fight or you want to give up. It's what do you want to fight for? Do you want to fight for a good day today or a good day later? And I said, it seemed like it'd been a while since you had a good day. And she said, yes, it has. It's been a really long time. So I said, is that a goal worth hoping for? Is that a goal worth fighting for? One good day. And 2 days later, she and Martin ended up leaving the hospital to start on hospice at home. I had to break the news to my daughter, Hunter, 13 years old, that she would not be having her piano lessons anymore, and that Peg was dying. She was struck incredibly low, said that she would likely not see her again. But then a few days later, we got a surprising call, and it was from Peg. And she said if my wife and I were willing, she would like to resume teaching Hunter again. Piano. That was more than I or Peg had ever imagined was possible. But I met her hospice nurse. Her name was Deborah French. And I asked her, what happened? How did this happen? And she said, well, she arrived on that first day, and they came and they talked about what Peg really cared about in life, what a good day would be for her. And then they worked to make it happen. And the first goal she had was just to manage her daily difficulties. You know, they got a hospital bed on their first floor so she didn't have to climb up the stairs, which she had great difficulty doing. They got a bedside commode so that she didn't have to go far in order to manage her bowel function. They worked up a plan for bathing and dressing, and then worked up a plan for pain, increasing the amount of morphine she was on substantially, adding a non-narcotic gabapentin for pain, and then adding methylphenidate, Ritalin, to combat the stupor that would be brought on. And as these challenges came under control, her anxieties fell away. Her husband Martin told me that she became focused on the main chance. She came to a clear view of how she wanted to live the rest of her days. She was going to be home, and she was going to teach. Now that took planning and great medical expertise to make it happen. You had to calibrate the medications. You had to get the doses just right so she wouldn't be in pain in the middle of the lesson, but not so zonked either that she would be talking with a stupor and freak the kids out, right? And it worked, and it worked. Martin said that she was more alive running up to a lesson and for the days after than he'd seen her in weeks. She'd had no children. Her students had filled that place for her. But she still had some things she wanted them to know before she had to go. She wanted to say her goodbyes, give her parting advice. And I think we in society and in medicine have forgotten how vital those matters are to people as they approach life's end, the things that they live for that are bigger than themselves, their loyalties. People want to share their memories, pass on their wisdoms and keepsakes, want to connect to loved ones and make some last contributions to the world. And that role, that opportunity, many people argue, outside of medicine, that opportunity is among life's most important. It is how life achieves meaning. And the ways that we in medicine, the way I've denied people those moments out of obtuseness and neglect is cause for our shame. We've had a 50-year experiment in medicalizing mortality, as treating it as a problem primarily of organ systems and control of evidence of disease. And that, I think, has failed. It's neither controlled the disease nor addressed the suffering at a certain point along the way. But it does not have to. And what's striking is a few skillful conversations, an understanding of ourselves as counselors can change that. It's defined by our ability to clarify people's goals along the way, identify what matters most, and then insist that our care respect that. Peg got to fulfill her final role. She lived 6 full weeks. Hunter got lessons for 4 of them, and then there were 2 final concerts. One was a recital with Peg's current students, who are all school children, and then another with former students, all accomplished performers from around the country. And they gathered in a living room, and they played Brahms and Dvorak and Chopin and Beethoven for their adored teacher. A week later, she fell into delirium and then died peacefully in her bed. My final remembrance of her, though, is this one. It's from near the end of the recital that my daughter played in. She stood with each child off from the crowd after they'd finished the concert, and she wanted to have a few words with them and give them each a gift she picked out. Hunter, she'd given her a book of music that she wanted her to keep and to learn. And then she put her arm around her shoulder and gave her one more gift. She whispered to her, "You're special." And it was something that she never wanted those kids to forget. And my daughter didn't. She's graduating from high school next week to go to school, the Berklee School of Music. It's made her entire career. That's what we can make possible. Thank you.
Well, thank you very much for that superb talk, very thought-provoking and very, very touching. We're going to have time for questions now. I would ask, if you wish to ask a question, there are microphones, which I can't see from here because of the lights, but there they are. And I would ask you that you use the microphones because this is being live streamed and recorded for eventual download. So please go over to the mics and we'll be ready for the first questions. And I think that's Mr. Goldberg, if I'm not mistaken, who's doing his traditional first question.
Dr. Asanji, certainly more meaningful lives is a desirable goal, but some question whether it should be the medical profession who are the chief agents in that situation. Aside of the fact that most doctors have not been trained with this area, there's also the possible unforeseen consequences, which some have talked about, that if doctors become increasingly associated with death and dying and palliative care and assisted suicide, people will stay away. People who have serious illness will stay away from hospitals and the medical profession. So has there been any research suggesting that a more active, dynamic, and more humane medical practitioners would only have these positive results and not unforeseen consequences?
Well, thank you for your question. I think it is really important, and I did try to emphasize this, but it bears repeating, and it often has to be repeated over and over again, that there is that palliative care is not the same as assisted death and assisted dying. And that, again, the goal is not a good death, but the goal is a good life all the way to the very end. And developing those skills to support people in that direction is crucial. Now, the question of whether, one of the ways in which the frame is so important is because we have come to equate palliative care or hospice with the idea of giving up and serving goals other than the ones that the patient has. One of the things I don't show on the survey is that about 85% of the population in Massachusetts, and I don't know how representative it is of the country as a whole or of Canada or elsewhere, but about 80 to 85% are people who feel that there is some level of quality of life below which they would say they would not want to have continued maximum aggressive care to keep them alive. About 15% have goals that they receive maximum aggressive care no matter what, that is the crucial goal that they have. And the key mistake we have is to fail both of those groups. It's to fail the people for whom they want maximal intervention, regardless of the condition of the quality of their life, and those for whom they want to clarify what those goals are for quality of life. And so, what I was describing earlier is the failure to have these conversations then leads to very poor care. The second part about it is that, in our studies and in also surveys, people do not find that these conversations lead them to have less trust in the profession. They lead them to have more trust in the profession. And that's because having an understanding from your clinician about what you're willing to go through and not willing to go through for the sake of more time, what kinds of goals you want to serve as part of your care along the way. Those are ways in which you become more allied, not less allied. For example, my father, in the course of his brain tumor, and I explained his course along the way, his first goal was he would do anything for the treatment so long as it was supporting his ability to continue doing surgery. He was a surgeon. And so there were certain treatments he did not want, and he found that and needed to be on the same page with the oncology team about those not being ones that he would want because it would sacrifice that career. Later, as that career did become sacrificed and he became increasingly quadriplegic, then the goals were to function well enough to be able to stay at home and not have that taken away from him, being able to travel a bit and see a few people along the way. So I think your caution is a right one. The Liverpool Care Pathway in the UK was an example of a well-intentioned palliative care protocol program that when rolled out across the UK, skipped the conversation parts with people and the goals of care planning, and still kept all of the medication recommendations. So what people experienced was no one discussing with them what their goals were, but being told watching a family member being given escalating doses of morphine and benzodiazepines, being deprived of, being taken away from food and water, and thinking that it looked like euthanasia to them. So it's absolutely crucial that at the center of this is the idea of control, and having to be able to, having the ability to define what your goals for quality of life and quantity of life are.
Thank you. I guess Dr. Hutchinson is next.
Dr. Gwandi, thank you so much. Such a wonderful talk. And you're focusing primarily on people whose survival is relatively short, where this is completely relevant. My question to you is, isn't this also relevant for people whose survival may be very, very long? Those two parts of medical care, one based on survival and function, the other based on subjective quality of life. Shouldn't we be considering that at all phases, and shouldn't we be teaching that to medical students?
Couldn't agree more. To my surprise, so as I started diving into this, I did not expect I'd end up writing a book that is half about care of the aged in senior living facilities. And the recognition that it's not just what matters to you in those last few weeks or months of life that turns out to matter, but at any point along the way where you become dependent on the support of someone else to manage in your life. When you have clarity about what your goals, priorities, and limits are, you are in line, you're much more likely to be aligned in the way you're being cared for. And when you do not, that's where you're much more likely to be out of alignment and therefore have suffering. And so as we've rolled out, for example, this program we've been doing it in primary care clinicians have relatively few people who die. On average, about 5 to 6 per year in their patient cohort. And so we are doing this in a large scale with primary care clinicians, and we'd be asking them, who do you have who wouldn't be surprised if they died in the next year? Did you have your conversation with them, et cetera? And they say, well, I only had one of those people this week, but I had this conversation with 9 other people with chronic illness. Can I get credit for that? And you can imagine someone on dialysis, for example, who really wants to find a way to stay at work and wants solutions that can get them there, but no one has asked. That's a kind of suffering as well. And it's absolutely crucial. And I think it's a lesson that geriatricians have long had, right? They will have people who will live with, it can be for a decade or more, with quite significant disabilities, but managing to have clarity about what matters to them along the way, and therefore tuning their medications, know the colonoscopy at 92 is not particularly helping anybody, and neither are the 8 medicines that are making them dizzy. What are our real goals here, and if it includes continuing to walk and function without falling, then those are changes that you begin to make. So I appreciate that line of conversation.
There's a question on that side.
Hi. I'm interested in hearing about what your vision for medical education is. Is it this 2.5-hour kind of intervention, or what beyond that can be done?
Yeah, and I'm glad you brought that up because I didn't get to manage to touch on that. So part of what's been incredibly gratifying since the book came out is seeing it become part of the curricula of many medical schools, which is flipping on its head a group of people who had been pushed out to the corners. Palliative care and geriatrics usually didn't get much airtime in medical schools, and having a chance to see them come back in, I think, is really important. I think we're still in the early phases of learning how to enable these skills. We have just announced about 3 weeks ago that we got that my center was able to negotiate an agreement between all 4 medical schools in Massachusetts to agree on coming together to have a best practices group for how to teach these skills along the way, and to commit to the idea that there would be longitudinal training. So it's not enough to have that training as a kind of one-off. it would need to be part of your longitudinal training to not just, I think most medical students now have formal training in a bad news conversation and having that effectively, but being able to then have a goals of care conversation, build on that, and build those skills in many settings, including on rotations in surgery or in oncology or in internal medicine and so on, are important, and as you weave them into chronic illness care management. One of the things we've learned along the way is that skills at prognosis giving really are quite advanced skills. That really is towards the end of residency, closer to fellowship or thereabouts. And so I think we're still learning and segmenting how you take what are very well-trained skills in palliative care and geriatrics and translate them into the non-palliative care trainee. But I think it's something that, you know, we're perfectly capable of learning to do.
Thank you. Dr. Wiggins?
In the context of the quality of that conversation with people and exploring their wishes, can you say something about the way we obtain advance directives as a routine in healthcare institutions, that piece of paper that we are under pressure to get signed within a finite amount of time under suboptimal conditions?
Yeah, there's several things. So there have been a number of studies about advanced directives, and none of them they're very sanguine. They don't show a lot of benefit from them. And often the way that advanced directives are written, kind of the boilerplate language is something along the lines of, you know, I do not want heroic measures applied if I should be in an irreversible state of disability, right? It's very unclear, and we don't know how to take action based on advanced directives. In fact, very few of us, I would say, probably use them to guide our care in fundamental ways. The main value seems to be that if you've had an advanced directive, it's prompted a conversation with your family members about what might matter. And given that about 70% of us come to the end of our life with with someone else having to make the decisions, that might be the only way that that discussion happens. It's clearly a set of building blocks, as I'm slowly learning. One is that very few of us have a healthcare proxy, and having that person designated who can be your agent. And then second, having a conversation with them about your goals along the way. And then third, an advanced directive is valuable, but part of the difficulty is it's really the ongoing conversation you need to have, because what really matters to you is in constant evolution. Like I described with my father, going from a focus on surgery to then a focus on being with family and friends and still being able to live at home and be around the dinner table, to then when his choices would have meant a ventilator and being a nursing home and a feeding tube, which he did not want, then it was just alleviate pain. And being able to have that as an ongoing conversation with people, also because we learn we may be more adaptive to situations than we thought we might be. And that's often the case. And so being able to walk our way through, I think, is crucial. And that can inform advanced directives. I'm not sure whether it's penetrated here, but the physician orders for life-sustaining therapy are turning advanced directives into physician's orders that actually live in your chart or are in nursing homes, and can be updated over time as people's views change.
Thank you very much.
Other side of the room?
Thank you, Dr. Gwande, for a very inspiring talk. So I'm a medical student here at McGill and an aspiring general and oncologic surgeon like yourself. And that being said, it's going to be at least probably 10 years before I'm face-to-face with my patient and having this conversation with them. So I'm wondering, for someone at my stage, you know, who's going to embark on residency in about a year, hopefully in that practice, what advice would you give in terms of practicing the principles that you're sort of...
Do you end up on call in the ER?
Sorry?
Do you end up on call in the ER?
Yes, yeah.
And when you're in residency at 2 in the morning, it will be you getting that call, not me. And invariably, I have these discussions with the resident over the phone. One that I had not too long ago was someone who had come in, transferred from a nursing home, who had right upper quadrant pain from an acute cholecystitis, acute infection of the gallbladder, and had a severe stroke that had left them hemiplegic and nonverbal, And the resident was saying that they recommended just putting a cholecystostomy tube, a tube in rather than surgery. And it was exactly the sort of situation where being able to have just a conversation with the family, and I walked the resident through having that conversation with the family until I had time to go in and see them, and at least long enough to stop the IR folks from putting in the tube until we knew what we really wanted to do. And the key part of the conversation was just saying to the family, what are your fears about his worsening health, because it had been worsening over time. And they said their biggest fear would be causing him pain. And that was really important to understand, because what we were going to accomplish there had many different options. We ended up treating just with antibiotic and ensuring he had good pain control for what was happening, as being more in tune with what the family thought was important. So I think you're going to probably find much sooner than you expect that this kind of conversation will be something that you will have almost any time you're talking to people who have complex illness, chronic illness. You'll find that it's a natural direction to go, is understanding what their goals are for not just the quantity of life, but their quality of life.
Thank you.
Atul, it's always great to hear you speak. Thank you again for coming to McGill. About 2.5 years ago, I was on call at the Royal Victoria Hospital on a weekend, and I was referred a patient from gastroenterology. I'm a surgeon, by the way, who was a patient who'd come in with anemia and been vomiting, and they found on endoscopy he had a tumor in his distal stomach. And I spoke to the resident, and we were excited to be able to do an operation, because that's what we enjoy doing, a subtotal gastrectomy. And I was like, this is great, we're going to do this. And we went and spoke to the patient and explained things, but we said, we'll just get a CT scan, just to make sure it hasn't spread anywhere else. We got a CT scan, and unfortunately it showed that it had spread to the liver and to the lungs. And so we couldn't operate. It wouldn't be right to operate on this patient. And I was upset, and so was my resident. But we went to speak to the patient, and it was a difficult conversation. And the other thing I have to add is I'd read your book just 2 or 3 weeks before on a flight across the continent, and the patient's wife was there, and the patient's son and daughter were there, and it became so clear to me that my mission was to cure this individual, but actually what I needed to do was to care for this person. And I really thank you for helping me with that. My question actually goes to another situation more recently, when I was in the intensive care unit, again on call, and there was a patient who did have a different type of cancer that had spread and had what we call as an acute abdomen, so a potential perforation in the abdomen. And I had a very good conversation with the wife, and she said, well, I'm not sure you should have any more surgery, and agreed that with the ICU physician. The shift changed, and another ICU physician came on call and basically said, no, we have to do this. This is his only chance. And when I look at your checklist, it reminds me of the checklist that you worked on with the World Health Organization, but there it's an acute situation where all together, the anesthesiologists, the nurses, the surgeons, medical students, whatever, to speak up. This is a more kind of delayed intervention with this checklist. So how do you work with a team together? It's great at Dana-Farber because it's been a mission across the hospital, but in different pockets where I have a conversation and someone else has a conversation, quite frankly, the patients probably don't even think that we know what we're doing. So how do you kind of work around that to make sure that we're all working together for the best care of the patient?
First of all, thank you for that, Raj. And just to say, I've found to my surprise, like you, that some of the most gratifying experiences I've had with patients is coming to understand what their goals are and then being able to make a recommendation where you feel like you're on the same side achieving those goals. And then it turns out we didn't operate. And I never thought that would happen, that some of my best experiences would be not operating. But I think it also brings home that some of the most distressing experiences I've had is where there's conflict over what those goals are, and even the concept of understanding what those goals are. And those conflicts can be with a family member who, you know, there's the famous seagull syndrome, where the family member who comes in, flies in from farthest away and craps all over the plan. It's a well-observed phenomenon. And also that, you know, in our era of multiple team members and people changing is the inability to keep the goal clear and in front of ourselves and to have a way of having clarity about it. So partly it's being able to have that be part of what we transmit, is what the goals are for, especially in critically ill patients, understanding, you know, an example is for a documentary version of this, we filmed people over the course of a couple of years, and along the way never realized that this one person who had a brain tumor didn't even ask until it was too late, that she wanted the full court everything, but also wanted to make sure she had a chance to take her grandchildren to Disney World. And you know, by the time it was realized that was one thing she wanted to have happen before the end, it was too late, and you never got there. And a lot of that was the disconnect between different clinicians never having this full conversation. You at least had that conversation. That increases the odds that they got the care that would be ideal. But, you know, it's still a fraction of us that are routinely having this, and so it's not a surprise that you have another team member come on who says, you know, what page are you on? I've never heard of this book. And then very hard to get to this place where you could conceive of saying, well, they have, you know, some key goals for the quality of the life, and they are really prioritizing that those are what we're trying to maximize. I think the key thing is that we think of it in a systemic way, and we do our best to, you know, have a frank conversation in those situations without coming to blows over these things, while recognizing what we're in the middle of is trying to shift our whole system over to one where we routinely recognize these. And I'll just make one anecdote tie-in, which is I remember going on rounds with the WHO team responding to one of the last polio outbreaks in India, and had arrived at the door of a mother who was refusing to take the vaccination despite the fact that there was another child in the village who'd been paralyzed. And when the local public health official started yelling at the mother, which only put her back up even further, the WHO officer started yelling at the public health official and pulled him out of there and said, you could wreck this entire mission in the first place. And so you start with where you can have the winners. There are plenty of people who are understanding and sympathetic to where we're going, and then we bring the converts along the way.
Thank you. So we just have a few more questions over here.
Yes, at least in the Canadian and American context, I submit to you that the reaction against paternalism hasn't been the only factor in, like, the neglect of this. So you can even see how, you know, it's like affected the practice of, say, psychiatry, which is essentially a human factor. So I'd ask you, in a heavily bureaucratized piecework, fee-for-service system, how do you incentivize for these sort of non-documentable human factors?
Yeah, it's a serious problem. I will get paid probably a couple $1,000s for the operation I do, and even if you pay me, you know, lavishly for the 30-minute conversation along these lines, the incentive always runs in the other way, right? So it's always going. There, on one level, I've said frequently that there is no incentive system that completely allies with ethics and the best care of patients, and that fundamentally it's professionalism that we have to continue to cultivate that maintains our ability to move forward. That said, I think that there are enough defects with fee-for-service medicine and a variety of ways in which it leads to unnecessary care that I think we are at a stage of needing to move beyond fee-for-service medicine for, not all of medicine, but for most of it. And this would fall into that area. That primary care is the classic example of where this is, are people who should be compensated on their ability to care people over time and be supported to do that, not on a fee-for-service basis. And part of that then would be that they are articulating the key goals that patients have and being part of orchestrating the full panoply of specialty care to meet those goals.
Yes, have a true relationship, not just be a taxi driver.
That's right.
I'm going to move on to the next question.
Hi, thank you for your talk. I think I still have a lump in my throat. You started your talk by saying that writing was a way for you to solve these puzzles, and I've really enjoyed over your career kind of how you unpack these individual experiences and look at kind of system level things. I work as an academic associate at the Writing Center, and we often talk about how writing is the medium in which we do our intellectual work. It's the work that's common across the university. But there's also a lot of research that talks about how writing is useful for emotional work. And I'm just curious, in the course of designing your intervention, if rather than having, or alongside having these skillful conversations, whether writing might be also a tool.
Yeah, so there's a couple thoughts about that. One is that I'm not entirely sure whether, in other words, I can imagine, you're getting me to think creatively here, which is that I can imagine there be a way in which people writing these out for themselves, and in fact there are a couple of workbooks that people have created that I found pretty fascinating, where it asks people, not just at end of life, but also for people who are going into senior living centers and so on, to tell your caregivers about who you are by filling out a set of things. And what I found was really fascinating was that this effort to describe who you are, who you care about, what your purposes are, what your life is like, but what you really care about in your life reflects in many ways the same discussion that we've been having. And none of them have really been tested properly, but I think could be really powerful. The second thing I'd say is I think it's really individual how writing functions for people. I remember doing a panel with 3 physician writers. It was Perry Klass, I don't know if you know her, she's a pediatrician who's written a great deal, and Samuel Shem, his real name is Steve Bergman, who did House of God. And the question was, why do you write? And Perry Klass said it was to understand relationships and explore relationships. Then I talked about, for me, it's finding things that confuse me and working my way through it. And then Steve Bergman said, to stick it to the man.
That fits with his book. I'm going to move on to the final question because we're running out of time. And
Yeah, I'm a bit short for this one. Hi, I'm a mental health nurse in psychiatry. I work with severely ill patients in psychosis, schizophrenia, and bipolar disease, but the worst of the worst. We're often, forcing our views on them. You need to stay moderately okay to live in society, so here's this pill and this injection, and take it and don't ask questions because we need you to be calm enough to live in society. And there's always that fundamental balance between making the general public at ease and respecting this person's wishes and reducing their suffering. And these medications come with a panoply of side effects that create really bad things for the clients individually, but on the other effect, if we don't medicate them, then we know that we're putting their brains at risk for a decompensation, then a further decrease in quality of life. So do you have a comment on that aspect of the seriously ill?
Yeah. So first of all, thank you for all the work that you do. Second, this gets at a really complicated set of ideas, which is that there are first order desires that people have, and then second order desires. So the first order desires are the ones like, I want that soda in the refrigerator, right? And the second order desire is, I don't want that soda in the refrigerator. And as clinicians, we're often trying to work to help people think about their second order desires. When you're asking someone to put on their seatbelts, to stop smoking, to address their nutritional issues, to stay on their medicines, to do this kind of work, we're asking them to think about their longer-term interests, their second-order desires, because we recognize they're working with people over time to achieve their second-order desires, their larger loyalties, the thing that they live for that are bigger than their moment-to-moment fleeting desires, is more gratifying for people and more likely to achieve what they themselves want to achieve. And with people who either have dementia or significant mental illness, that is much harder because the first-order desires dominate the second in extreme ways, and they're much more difficult. And then so you're left in the position of either trying to, I write about a few people who have pretty significant dementia in the book, but you could observe in them, it's like the woman who had severe Alzheimer's disease, you could observe where their joys and where their satisfactions in life are from and are coming from, and what gives them that better course of life that allows them to be in the place that they ultimately find is better for them than the ones where they're only going after those first-order desires and doing the impulsive thing. And so it makes your job, people who work with psychiatric patients or with patients with severe dementia, that much more complicated because you're trying to recognize where the joys are at that first-order level and they're just simply gratifying, or where they're self-defeating, and then to help people through them. But that I think is part of the nature of that job.
And we're going to stop there. We're way over time, but it was well worth it. Thank you very, very much for the superb
Thank
lecture
you.
and the superb answers. I have a very small token of, to recognize this event that I
Thank you.
now hand to you, and that we get our picture taken.
Okay. Thank you, everyone.
And we'll set it up so it gets safely back.